Chapter 29, Promoting Urinary Elimination. These are the objectives for this section of the chapter. Okay, so the urinary system um, provides a means for removal of liquid waste from the body. And so it contains kidneys, two kidneys, which are two bean-shaped organs that's located at the level of L1 on either side of the spine. And each kidney contains approximately 1,000,000 nephrons. And the nephrons are the working units of the kidney, what helps the kidney to work. And then from there, we go to ureters. We have two ureters coming from each kidney, and those are hollow tubes that carry urine from the kidneys to the bladder. And then um, the bladder is a muscular organ that's located in the pelvis that stores the urine. And then from the bladder, we go to the urethra. The urethra carries the urine from the bladder to the meatus, which is where the urine exits the body. The urethra in the male is about 8 inches or 20 centimeters, and in women, it's about 1.5 to 2.5 inches or 4 to 6.5 centimeters in length. Okay, so under normal circumstances, emptying of the urinary bladder is a voluntary action, and it relies partly on um, a properly functioning neurologic system. So the kidneys, the function of the urinary system, um, we have a few things. So the kidney serves for helps with acid-base balance, water balance, electrolyte balance, toxin removal from the body, so it filters the blood and removes any toxins, blood pressure control, production of erythropoietin, which produces red blood cells. And you know the red blood cells carry oxygen from the lungs to the rest of the body. And then it also helps with vitamin D metabolism. Okay, so like we said, the bladder stores urine until it's ready to exit the body. So usually when it's around 250 to 400 mLs in the bladder, there's a signal to let you know you need to, empty the bladder. Um, and this is under voluntary control. As a rule of thumb, um, you should be emptying about 1 ml of urine per kilogram an hour, which for your normal healthy adult should average out to roughly about 30 to 70 mLs per hour that you should be um, urinating. If it's less than 30 mLs an hour, then the patient might be experiencing some kind of decreased tissue perfusion or decreased cardiac output or something of that nature. Um, Anytime a patient has decreased cardiac output, their urinary output is going to decrease. Also, keep in mind that you don't want to hold your bladder for long periods of time if you have to urinate. Your bladder can hold up to 1,800 mLs. However, you don't want to just keep holding it for that long, because what's happening if you keep stretching, it's a muscle. So if you keep stretching it out of shape, if you keep stretching it, all that time, when people get older, their bladders tend to weaken because you've weakened that muscle over a period of time, which increases your risk for incontinence in older adults because the bladder is, weakened uh, from those, doing that over years. So as I previously stated, the bladder can hold between 1,000 and 1,800 mLs of urine, but you shouldn't necessarily, hold it that long. Um, Average urine output in a day should be at minimum 1,000 to 1,500 mLs a day. But obviously, if you're drinking more, you should be urinating more. You need to be urinating at least 600 mLs in a day to remove, waste products. You have an internal sphincter, which is between the bladder and the urethra. And then you have an external sphincter, which is between um, the end of the urethra. Um, and it's controlled voluntarily. So when you're ready to uh, urinate or void, then um, you voluntarily control that external sphincter to allow urine to exit the body. Any type of spinal cord or pelvic nerve damage can cause you to lose voluntary control as well. So when you have damage to the spinal cord or um, some type of nerve damage in the pelvic area, you could have voluntary loss of control over that external sphincter. Okay, so numerous things can influence the production of urine, or the production and excretion of urine. The spectrum of influence and variables can range from those that are part of the person's everyday activities to deviations that are related to different health issues. So, for example, the kidneys regulate the amount of urine produced based on the person's activity level and fluid intake. So if the person engages in very strenuous activities that result in significant fluid loss, such as sweating or rapid breathing, but they don't take in enough fluids to compensate for the fluid loss, then the kidneys will reabsorb fluids to maintain balance, and the urinary output will be decreased. Some other health issues, such as hypotension, um, diabetes insipidus, enlarged prostate gland. All those things can also alter the urine production, urine excretion, or even both. And so, these are different things that can affect. But you have lots of blockages, um, structural obstructions that can block, such as kidney stones, tumors, trauma to the lower abdomen, like I said, enlarged prostate, trauma to the urethra, infection, neurologic damage, all these things can impact. So if we had things like tumors, prostatic hypertrophy, stenosis, which is narrowing of the ureters or the urethra, they all can interfere with the outflow of urine, in addition to affecting voiding patterns. Obstructions may lead to backflow of the urine into the kidney, which can result in kidney damage as well. Neurologic injuries, any condition that causes damage to the neurologic centers that controls the bladder function may result in urinary retention or even urinary incontinence. So for example, if you had a stroke or if you had a spinal cord injury or something like that, that can also impact, a person's urinary output. I talked about hypotension. Urine production requires an adequate flow of blood to the kidneys. So individuals that have hypotension will have low blood pressure. So anytime you have, remember this, anytime there's decreased blood volume or uh, fluid volume in the body, you're going to have decreased blood pressure. So, hypotension, if you had increased fluid volume in the body, that will cause your blood pressure to increase, causing hypertension. Okay, so older adults have a lot of different changes occurring as far as their urinary system that could cause them to have diminished urinary function. Um, that results in more instances of urinary incontinence or increased risk for urinary tract infections. So there's a decrease in the number of functioning nephrons. So the kidney itself um, functioning is decreasing, the decrease in their filtration rate. The filtration rate is the amount of blood that's being filtered through the kidneys. That is in itself is starting to decrease. The actual bladder size decreases, causing more urinary frequency, so they can't hold as much in the bladder, and so they have to go more. As we talked about before, if you um, stretching that bladder all the time instead of urinate when you need to, and you're stretching that bladder out all the time, and it causes your that bladder tone to be decreasing, possibly causing incontinence or nocturia. Nocturia is having to urinate at night a lot. Men enlarge prostates, and so that can cause urethral obstruction because the prostate surrounds the urethra, and so that can cause um, uh, issues for men. So the bladder capacity in older adults remember I said your bladder a normal healthy adult can hold 1,000 to 1,800 mLs of urine. But when we talk about older adults, their bladder capacity could decrease to 200 mLs and only holding 200 mLs. So like I said, they have to go more frequently. And so a lot of times our older adults, uh, maybe they start to drink less so that they don't have to go as frequent, or um, maybe so that they don't have incontinence as much, so that they drink less, which causes other issues because they're not flushing out their kidneys like they need to. So, and then that can increase the risk for urinary tract infections. Um, Decreased estrogen, and for women, decreased estrogen causing a thinning of the urethra and the vagina, which also increases the risk for infection and incontinence. So, some healthy lifestyle interventions to prevent or minimize urologic disorders. You want to drink at least 2,000 to 2,500 mLs of water a day, every day, to properly flush out your kidneys. You want to empty your bladder sooner rather than later, because also, like I said, that decreases your muscle tone, but also when you're holding that urine in the bladder for extended periods of times, um, that allows for bacteria to grow. And so then that can increase your risk for infections as well. So you want to empty your bladder sooner rather than later. Control your blood pressure. Good blood pressure promotes good kidney function. You want to avoid routine use of over the counter drugs. You want to wear cotton underwear and avoid nylon or constrictive clothing, because that promotes moisture and increases your risk for infection as well. Okay, so like we said before, there's a lot of different things that can impact um, a person's normal urination pattern. If they had neurologic or muscle um, issues or concerns, that could impact their ability to normally urinate appropriately, or having incontinence, or having retention, or not being able to urinate at all. If it has some kind of spinal cord injury or something like that, you're not taking in enough fluid, that can cause you to have dehydration, excessive fluid loss. If you're ill and you're perspiring or sweating or having excessive diaphoresis, vomiting, diarrhea, all these things increase your risk of fluid volume deficit. The ADH hormone is secreted by the pituitary gland. So if you had not enough or too much of the ADH, antidiuretic hormone, that can impact your urine output as well. Okay, so characteristics of normal urine. So if you do a urinalysis, you're trying to see if there's, uh, infection present or whatnot. So normal urine should have a straw color or amber colored um, urine. It should be clear, transparent. Um, possibly slightly cloudy, but it shouldn't be anything more than that. There may be a faint odor of ammonia, but it shouldn't be anything strong smelling or foul smelling. The specific gravity is the thickness or thinness of how thick or how thin the urine might be. If you're dehydrated, it might be thicker or more concentrated. If you're have fluid volume overload, then it could or if something like diabetes insipidus or something like that, um, it could be, very pale, very dilute. So a normal specific gravity would be 1.010 to 1.030 would be your normal. Now, your normal pH, remember we said is 7.35 to 7.45. When we're talking about the pH of the urine, different places you look, it might be off different just a little. Some places you might see it say 4 to 6, some so 5.7 to 7. But either way, it should be more on the acidic side. Um, that acidity also helps to fight off bacteria. And so, you want that urine to be a little more on the acidic side. Okay, so these are some terms you need to start to get used to and knowing your terms. You got to know your terms because a lot of times that's how you get questions wrong because you don't know what a term might mean. So when we talk about anuria, that's pretty much no urine. So that's going to be less than 100 mLs of urine in a 24-hour period. Um, Dysuria is painful or difficult urination. You might have infection or something like that. So a person like with a UTI or something, you might, if you see dysuria, that means painful or difficult urination. Incontinence is involuntary release of urine. So remember we said urination is a voluntary action. There's different types of incontinence that a person can have, and so if it's involuntary release of urine. Um, Nocturia is when a person has to get up more than twice in a night to urinate. Oliguria, so anuria is almost no urine, so that's less than 400 mLs in a 24-hour period. Oliguria is decreased urine output, so that's less than 400 mLs of urine in a 24-hour period. And polyuria, anytime you see the word poly, the prefix poly, that means increase. So polyuria is excessive urination. Excessive urination, it's going to be more than 1,500 mLs um, in an hour. A couple other terms I want to make sure you understand. Um, Urinary frequency, uh, that's voiding or urinating in very short intervals, so you're going quite a bit. Urinary urgency, that's a strong sensation to empty the bladder regardless of the amount of urine or how full the bladder might be. And then hematuria is blood in the urine. Pyuria is pus in the urine. Anytime you see that suffix urea at the end, you know it has something to do with urine. Okay, so cystitis. So that's what we're talking about. That's a type of UTI. So that one is in the bladder, cystitis, inflammation of the bladder. So when we've got urinary tract infections or UTIs are the second most common type of infection in the body. Um, and they most often affect the lower urinary tract because microorganisms have easier access to the structures in the lower urethral meatus. And so the most common cause of UTIs is E. coli, and E. coli is found in the stools. And so that's why we always want to teach our patients to make sure they wipe from front to back because they don't want to risk bringing stool up to the urinary meatus, allowing bacteria to get into the urethra, causing infection. Women tend to have UTIs more often than men, probably because, like we said before, the urethra in women is a lot shorter than in men, and so the bacteria has a shorter distance to travel. So we can have a UTI in the urethra, and then that would be as infection in the urethra, that's urethritis. And then infection in the bladder is cystitis. And in pyelonephritis is infection in the kidneys. So some symptoms you might see when we talk about UTIs or urinary tract infections are urinary frequency, urgency, dysuria, burning, malaise is just a feeling of weakness, foul smelling urine, slight temperature elevation. Now, I want you to make note that when we talk about our older adults, they may not have any of these symptoms, may not have a fever or any other of the typical symptoms of a UTI. The only thing you might notice in an older adult is an alteration in their mental status. So, for example, there's some maybe some confusion or some type of behavioral symptoms like confusion or something like that. So, some type of alteration in their mental status. That may be the only thing we notice in an older adult. Okay, so we got different ways we can collect a urine specimen. So a normal voided specimen um, is clean but not sterile. It's collected from for just like a routine urinalysis or something like that. Um, you want to make sure it's not contaminated with feces, although it's not sterile. You want to send it to the lab within 5 to 10 minutes because if you allow it to stand for more than 15 minutes, then it can change its characteristics. A midstream or a clean catch is a sterile specimen that's collected for culture and sensitivity tests. And so you're going to use a sterile specimen cup, and the urinary meatus should be cleansed with sterile wipes when collecting a voided specimen. Now, you can get urine from, if a person has an indwelling catheter, you can get urine from the indwelling catheter itself, or you can get a sterile catheterized specimen using straight cath. A 24-hour specimen is a specimen that's collected to measure the quantity of a particular substance in the urine within a prescribed time frame. And so the patient is instructed to void, discard the urine, um, the first urine, and record the time, and then collect all the urine in the provided container over the next 24 hours. And so if they start at 8 a.m., they'll urinate, discard that urine, and then collect all the urine for the next 24 hours. Then 8 a.m. the next day, they'll urinate one last time and collect that specimen as well. And in a strain specimen, that would be maybe the person has kidney stones or something like that, and they're trying to, ensure that the stones pass. And so they'll strain the urine to see if it passes. Okay, these are some more terms for you to get used to. Remember when I said when you have urea at the end, that should be your hint that this has something to do with urine. So glycosuria is glucose in the urine. Protein urea is protein in the urine. Hematuria is blood in the urine. Pyuria is pus in the urine, and ketone urea is ketones in the urine, and you have ketonuria, like with diabetic ketoacidosis or something like that. None of these things should be in the urine. So if you see these things in the urine, that's something abnormal and should not be present. Okay, so when conducting a urinary assessment, you want to make sure you assess all of these things in your patient. What's their normal pattern? What's their usual pattern of urination? How do they, what time of day do they usually urinate? Um, things like that. You also want to assess fluid intake. Do they have incontinence? Do they have frequency? Do they have urgency? Do they have burning when they urinate? Um, so you want to make sure you're assessing all these things when you're assessing a patient's urinary status. Does it have an odor? All those things as well. Okay, the urinary system is made up of which of the following structures? And so your answer here is going to be 1. So the urinary system is made up of the kidneys, the ureters, the bladder, and the urethra, for male and female. Just remember the urethra for the male is a lot longer than that of the female. And the prostate is only present in the males, and it's not considered a part of the urinary system. A urostomy, that's an opening in the ureter, where the ureter uh, exits the abdominal wall to allow urine to uh, exit the body. Okay, question 2. Erin's patient has been complaining of burning when she urinates. Her doctor ordered a urinalysis which shows pyuria. These results indicate, so that's going to be 4, pus in the urine. So remember, pyuria is pus in the urine, and that usually means bacteria is present in the bladder or the kidneys. Proteinuria is protein in the urine. Bilirubin in the urine suggests liver disease or an obstruction in the bile duct, and then hematuria is blood in the urine. These are the objectives for this section of the chapter. Okay, so we have different types of urinary catheters that we can use, and so we've already practiced inserting an indwelling Foley catheter. And so remember, an indwelling catheter uh, is different than a straight catheter in that it has an inflatable bulb that's filled with water to hold it in place for as long as the catheter is to remain in the bladder. Um, and so the straight catheter is a device that's used to obtain a sterile urine specimen. So you just insert it, get your specimen, and withdraw it. It can also assess for residual, if you think the person's having residual or retaining fluid or anything like that, if you need to relieve bladder distension. So a straight catheter is not left in place, whereas an indwelling catheter is going to be left in place. The condom catheter, that's an external device that consists of a condom, tubing, and drainage bag, and it's secured to the shaft of the penis using a special adhesive to prevent constriction of the penis. The adhesive should be applied to the shaft of the penis in a spiral fashion, right? We talked about the cont'd, that was the catheter that had um, uh, a curved tip for people that's having some anatomical issues to try to insert a catheter or whatnot. Um, so suprapubic, that one goes is surgically inserted via the abdomen to try to it straight to the bladder. So you got, like I said, different types of catheters. Remember, anytime we are inserting any foreign object into the body, such as a catheter, we put our patients at risk for infection. So we have to be careful. A, a, a urinary tract infection that's related to a catheter is called a cont'd, which is catheter-associated urinary tract infection, and that's the most common type of infection in hospitals, and it's easily prevented by one, making sure you're using sterile technique when you're inserting the catheter, and frequently cleaning the area around the catheter, and practicing good protocols. So, um, we don't want to just put a catheter in a person maybe just because they're incontinent or something like that, because we are putting our patients at risk for infection. Now, if they had a sacral wound and they were incontinent, then that would be a reason to put in a catheter, because we don't want to get the urine in the sacral wound. But if they're just incontinent and we don't feel like changing uh, diapers or depends or whatever, that's not a reason to put in a catheter. So you want to make sure you're constantly assessing the need for that catheter, and when it's no longer needed, you're going to remove it. Okay, urinary incontinence. That's the inability to control the bladder or controlled bladder emptying, I should say. It could be temporary or it could be chronic, and it occurs for various reasons. Also, remember a patient who has urinary incontinence might not disclose it to the doctor because he or she might be embarrassed about it. Also, the person might refrain from activities that involve interaction with others because they fear they might have urinary leakage or an odor that occurs, and afraid that people might notice it. Also, keep in mind patients experiencing chronic incontinence are at risk for skin breakdown. So you want to make sure we're cleaning properly so that because remember we said the urine is on the acidic side, and so that sitting on the skin puts them at risk for um, skin breakdown. So different types, like I said, there's different types. We have functional incontinence, which is involuntary voiding or urinating in a person who has normal bladder or sphincter control. And so people that have uh, cognitive or sensory impairments might have this, or some type of motor impairment or whatever, or maybe environmental constraints. They're constrained, they can't, get to the bathroom, um, or whatnot. Overflow, that's leaking urine from an overfilled bladder. So people with like a prostate gland that's enlarged. Remember, I said that prostate surrounds the urethra. So then you have urine that's leaking around that prostate gland, or uterine prolapse, or spinal cord injuries, things like that. Stress incontinence, that's involuntary loss, just a little bit less than 50 mLs of urine, um, due to increased intra-abdominal pressure from like coughing or laughing or sneezing or something like that. Urge incontinence, that's a strong sensation to void, but the person cannot delay the voiding until he or she reaches the bathroom. The amount of urine that's voided can vary. And then mixed is a combination of any of the previous ones that I've stated or whatnot. And so, one thing that people might do to try to um, strengthen their pelvic muscles are Kegel exercises. And so, Kegel exercises um, strength helps to strengthen the muscles that's used to start and stop urination. First, you want to squeeze and hold the contraction of the muscles that's used to stop urinating for 5 seconds, and then relax for 5 seconds. And so gradually increase it to like 10 seconds. And you want to do this every day. You can teach your patients to start to, you can teach your patients to practice when they're urinating. So tell them to practice stopping their urination and then releasing it, and stopping it and releasing it, to get a feel for what Kegel exercises would feel like. And then they can do it at any time. It don't have to be, once they understand what it feels like, they can do it at any time, several times a day. They could be driving, they could be sitting watching TV or whatever, once they learn how to do it. Okay, so urinary diversion, that involves rerouting the ureters to the abdominal wall for excretion of the urine from the body. And so the diversion may be temporary or it may be permanent, depending on the underlying reason for the procedure. And so patients who require a urinary diversion lose their ability to control urine elimination. And so they may experience problems with skin breakdown as well as alter body image. So remember, I said that the urine is slightly acidic, and so and it may contain a little ammonia. So that increases the person's risk for skin breakdown. Just like with incontinence, you want to make sure you're practicing good skincare and preventing allowing that, and don't allow that urine to just sit on the skin. Okay, so you want to make sure you're documenting very well when you're documenting about a person's urinary status. When a patient is voiding normally, are they voiding sufficiently, whether they're having any problems with voiding, such as dysuria, which we said was painful urination. Do they have any burning when they urinate? Do they have urgency, frequency? Um, are they continent or incontinent? How much urine they're putting out? So you want to measure INOs, intake and output. Do they have bladder irrigations? Also, remember with bladder irrigations, when we're talking about intake and output, you want to subtract the amount of bladder irrigation from the urine output. So, for instance, say a person has a Foley catheter. If they have a bladder irrigation of 2,000 mLs, right, and then you go to empty that that Foley bag, and there's 4,000 units of fluid in that Foley bag, you're going to subtract the 2,000 of bladder irrigation. So that output would just equal 2,000. And then also, if they do have a Foley catheter, you want to document that. You want to document the characteristics of the urine as well in that Foley. Okay, Brenda is making rounds on her postoperative patient. She notices her patient's Foley has drained 90 mLs in 3 hours. Which statement is correct? So the answer here is going to be 2. This is an average amount of urine output. So remember, there should be an average hourly amount of 30 mLs of urinary output. Aaron's patient will be going home with a catheter. All of the following are true regarding a Foley catheter except the answer is 3. The balloon is inflated to 15 mLs. So you're going to inflate it based on, whatever the catheter says. A lot of times is, somewhere between 5 and 10. Bruce's patient needs a condom catheter. This type of catheter is used when the answer is for a male is incontinent. So a condom catheter is used for males who are incontinent but can void on their own. An indwelling catheter is used for a patient who cannot void or for a man or woman following surgery. And the female incontinent patient may not wear a condom catheter.